Welcome today to our first regular program for the new academic year. Today, as a visitor, we have Jim Stowe. He is the Director for Aging and Adult Services for MARC, which stands for Mid-America Regional Council, which is an association of various entities in the region that provide services from cradle to grave, I would almost say. So we hope to hear from him about his specialty and how his institution can help us in aging and what type of services they provide. Put that one in your corporate.
Okay.
Yep. And now I'm going to share the PowerPoint and activate it.
Great. Well,
and it should be possible to forward now as well.
yeah, looks good. Great. Well, thank you for having me. I really appreciate the opportunity to share with you all today. I actually have a history as a faculty member for a brief stint right after my graduation at Washington University School of Medicine. And we worked in nutrition and geriatrics and made the leap from research faculty to really applied work at the Mid-America Regional Council, which is what I'll go through today. I hope to immerse you in sort of the structure of what we do with our service funding and how that is attempting to answer some of the major questions of our time with what do we do with a rapidly unprecedented aging population, and how do we make people's lives meet their expectation for the aging process, and how do we really, as a society, respond to this challenge and opportunity that's been presented to us. So I will talk a little bit about MARC as an organization, and then we'll talk about aging services, and then maybe if we could have an interactive portion of question and answer or suggestions to me about how to do my job better, I'd really love to access some of your wisdom and experiences as well. So MARC is a voluntary council of governments. That means that when governments want to collaborate across jurisdictional lines for major problems that they're facing, MARC is an entity that carry that work forward and make sure that mutual interests are advanced, mutual funding can come to bear on problems and issues, and resources, including thought leadership, can be convened in one location and solutions facilitated by that collaboration. We have many departments, as was alluded to. We kind of call it womb to tomb type of services, or cradle to grave. Our early childhood department runs the Head Start program for the region on the Missouri side. And we have environment, transportation. We have a research services department that helps with data and forecasting for planning, community development, local government services, and then aging and adult services. So those areas of function at MARC really kind of empower this regional council of governments to be a little bit broader than what you might find in other areas of the country, and extended beyond a metropolitan planning organization, which typically, if you see those around the country, they're largely focused on transportation initiatives. Our aging department has funding primarily from the federal government through the Older Americans Act that was passed in 1965 with a focus on keeping people in the community for as long as possible. There is a societal will question with the Older Americans Act. Where do I want to age and go through the aging experience? And that's typically in my home. And there's also a question of cost to the government, which it's obviously much less expensive to keep people in the home than build up institutions and fund those institutions for skilled nursing care, et cetera. MARC has a contract approach to an area agency on aging, which were started under the Federal Older Americans Act. Area agencies on aging in some way, shape, or form touch every part of America, and we serve Jackson, Platte, Clay, and Cass and Ray counties, excuse me, and on the Missouri side of the metro only. We have sister organizations that serve the Kansas side. And our model is to not offer services directly. In fact, we align quite nicely with the original intent of the federal legislation, which is we find community partners, either for or nonprofit, who are direct service providers, and we pass dollars through them and act as an economic engine for the region by taking those federal monies and allocating them to service providers. They will use that to advance their mission to provide the service and provide jobs and other resources to the community. We also, beyond the Older Americans Act, have Medicaid funding that's coming through the state. In fact, in some Medicaid programs, the area agencies on aging are designated as a provider. So two primary areas: home delivered meals for Medicaid recipients who are under home and community-based waivers, and reassessments for Medicaid eligibility. The area agency on aging will handle that. We do a lot of grant work. Grant writing is a big part of our portfolio. And so independent grants, either local philanthropy, federal government, state grants at times, we will write and land. And then there is a match requirement for in-kind donations that kind of round out our funding portfolio. On the Missouri side, with the COVID relief, we're at about $10 million per year in funding. So not a lot of money, but not insignificant. And without the COVID dollars, we're about half of that. The clients for the Older Americans Act, they are not means tested. So there's no check for income, but we do prioritize services based on how the statute at the federal level was originally written. So priority groups include people with diverse backgrounds, individuals with limited English proficiency, and elders who dwell in rural areas, including all the way down to the southeast corner of Cass County. These are some of our services that we offer. I'm not going to read through this list. You can see it's comprehensive. Really, the intent here is anything that you think an older person who enters into a period of dysfunction or lower function in their older adulthood, what would they need to remain in the community? What supports would have to be put into place to make sure that they are healthy and thriving? And those services really provide that array and mix. One thing I'll point out that we're constantly battling is housing. And the federal government has deigned that they will fund housing through the Department of Housing and Urban Development. So they won't carve off separate dollars for that expense. So some of the areas in our services do face gaps, but if you have housing on your own, we can care for you where you are. Our flagship service line is nutrition. We have a lot of individuals in our region with food insecurity or limited food resources. And we fund meals either at congregate centers, commonly referred to as senior center, although we don't like the vernacular that's arisen around that, but also home delivered meals. So if you think of Meals on Wheels, the daily delivery of a hot meal or the weekly or bi-weekly delivery of frozen meals, we operate those programs. And again, through partners in the community. There's a whole title under the Older Americans Act that is labeled supportive services. And it's sort of the kitchen sink approach to the other services that you might need to remain independent. So we have a very strong information and referral service. We contract with United Way 211's call center to operate our information and referral. We have 3 full-time positions placed at United Way of Greater Kansas City. They're well-versed on resources and use the 211 database to connect callers with resources in the community, or if eligible, they do our intake, and then that flows right into our process of service delivery at MARC. It is becoming more important as we wrap services around really high risk, complex individuals with complex medical and social needs, that we have a care manager sort of at the center of that case, and they can help to coordinate and navigate the extremely complex systems and funding streams that make up, the array of services that people need. So we're actually elevating that, and I'll tell you a little bit more about our efforts in a little while in care management. And then transportation, one of the tremendous challenges of the Kansas City region is how spread we are. And if you've ever tried to get from one point of town to another without your own personal vehicle, it's very difficult, and we have not solved that challenge. I'll just tell you that honestly. And then a few other services for supportive services that are very helpful. We do have a whole title related to caregivers. So caregivers are acknowledged in the Older Americans Act as a huge asset to society. We know that they are very low cost for very high quality and high volume of work for those that they're providing care to. And we offer supportive programming that helps maintain that caregiver relationship. Largely, it's around training and support.
So if you say caregivers, is that like family, friends, or is it wider than that?
The title is actually called the National Family Caregiver Supportive Program. So it's really focused on those intimate relationships where they're cohabiting a residence. That's where the act really is unleashed to its full potential, and we can provide any service that we have under our portfolio. However, the caregiving relationship is acknowledged to be valuable beyond that. And so there are other services that can be rendered to those who are not cohabiting, to adult children, to fictive kin. I mean, there's a lot of ways that that can be defined, oftentimes by the recipient of the care. They will define their caregiver and we will render the service. So we try to be as liberal as possible in our interpretation of who the caregiver is, to acknowledge that relationships and family structures vary across individuals. Most of our caregiver work mirrors our other funding sources. We've just identified that in this case, there's a caregiver dynamic, and that's what we're trying to support. We are very proud to have recently launched, last year, in fact, a home modification and repair service line. One of the most frequent things that we faced in our service delivery is, I have a minor home issue like a roof leak. I'm gonna get submitted to the code department and evicted, and then I will end up in a skilled nursing facility, which is against our mission. Or I just need my doors widened to accommodate my assistive device, and otherwise I'm going to, again, be in a facility. So this program service line was started using COVID relief dollars and ARPA dollars to meet that need in the community. The federal statute was written with a regulation in 1988 that said this service line across the country may not exceed $150 per project, which didn't really meet the modern needs for home repair and modification, as you might suggest or might know. We did work with the state, though, to get that changed. And remarkably, in a state like Missouri, they changed it to $5,000 per project without state approval, and up to $10,000 if we approach the state unit on aging for their approval. This has had a remarkable impact. I've been on some of these sites personally, and it is amazing that just a little bit of upkeep, a little bit of repair modification can keep someone stably in their home. And it's really hard to access resources for that type of work in other places. We do cross the boundary into skilled nursing facilities as far as a long-term care ombudsman program. So if you have a complaint or need to voice your rights as you're living in a skilled nursing facility or other institution for care, we have ombudsmen who work to be a neutral advocate to support your rights, carry your voice forward, and find a solution to the problem that you're facing. That happens through professionals that are placed in our department, and they recruit volunteers who will go to specific facilities and be a regular face, voice, and can visit directly with residents. But a great way to identify things and situations where the client would never be able to have a platform of, voicing their opinion and their need. So just so you know, if you're out in the community in your personal lives working with your parents or your spouse or whoever, and you need to know how to access these services or make that referral to someone else, the absolute best way is to give them our information and referral phone number, which is 816-421-4980. I'm sure Jacob will throw that through manipulation of these programs on. No, I'm joking. We can provide that later for you guys to have as a resource if you want to make a referral in. But they go through a very brief screen. We try to understand the needs. Sometimes people will call in with a need at the top of their mind, and we'll try to talk them through some other options and what they're facing. And then the service will be rendered after an in-home assessment. And one of the things that does distinguish area agencies on aging is stepping foot into the home whenever possible and when COVID's not present and all of those things, but to really get a good view of the environment, take a look at the functional issues that the older person is facing, and try to offer them additional services if we think they might need them or if they request them. We were very, very pleased a few years ago to launch one of these consumer-directed approaches to care. And it has actually served as a proof point for how we operate our services. And we are morphing our federal services to look more and more like this program as we've gained experience with it. And that program is a veteran-directed care program. The VA Medical Center will identify one of their patients who they hold total responsibility for their well-being and medical care as eligible for the program, and they'll make the referral to our organization. We have professionals called options counselors who goes and works directly with the veteran and allows them to spend down a monthly allocation for services that they see fit. And they will act as the employer and hire a caregiver. They will make decisions about spending on equipment, a savings plan for their needs, and they will put that into a budget, and we will help them act as their own employer of their caregivers and whatever resources they might need to advance their case. This means that they stay out of the nursing home and they really are totally in charge of how they receive care and support. The highest, they call the monthly allocation a case mix. It's according to function. And the highest case mix right now is $16,000 per month. Typically veterans who have ALS or other highly debilitating disease processes. We have individuals who are receiving suction every 5 minutes, typically from a spousal caregiver or other close family member caregiver to keep them in the home. And the program actually works. Remarkably, you can stay in your home with that level of care. And in fact, the veterans tell us that they could not stay in a facility and still receive that level of assistance, and this is their only option. It has 98% satisfaction rate among veterans and very, very effective. Yes, sir.
Does this involve at all the VA system, or does it overlap with anything?
The question is, does this program overlap with the VA or involve the VA system? Yes, directly. So this will actually, the veteran will transfer from another VA program to veteran-directed care, and then that will become their kind of support from the VA. It's encouraged at every veteran medical center across the country, but only a few have actually adopted and moved it through. And the Kansas City VA Medical Center is one of those.
So you said you're going to try, or you have been doing this type of model for your other clients. Now I can imagine that persons can act, whether they're veteran or not, ask for what care is appropriate. But obviously there was far fewer resources that you or the individuals can get if they're not veterans.
Yeah, that's exactly right. So we have tried to take the idea and concept, which is choice, autonomy, and people kind of running their own care, because this may be hard to believe, but people sometimes know what's best for themselves. So we've tried to take that concept and spread it to our federal funding, despite the limitations of funding. But really, when you look at what we can do with our federal dollars, it's all service and unit based. The state loves me to sell them widgets. I've sold, 25 meal widgets this month. They like that type of thing. So it's not just a free check, obviously. But when you add up all of those services, it actually turns out to be an array and a portfolio that is pretty supportive. And you can really handle some pretty complex medical and social needs just using the federal funds. But you have to have a commitment to a model that really lets the client have a very strong voice in how they want that ordered and how they want that to be orchestrated in their case. And we've tried to do that as much as we can. And we've actually exceeded, we'd have previous budget limits on per person service maximums just to make it look like we had enough reach in the community. And we've started to flex that to be more dollars per individual case because we think it's such a brilliant idea and such a relief to the client receiving the services. So we've done that for what's called in-home services, when you have a caregiver, a care worker coming into your home. Could be a family member, it could be an agency. And we've also done it for transportation, where they get to select their own provider, and they don't have to be told by us which taxi company or whoever provider is going to come to your house. And again, it's worked very, very well. People do really enjoy having that autonomy. So we hope the VDC program is extended. We know it's saving the government up to 40% on each individual veteran with much higher outcomes and satisfaction. I talked a little bit about our Medicaid revenue. Just know that that's an important array. We actually earn margin on our Medicaid services that we provide to the state of Missouri, and we wrap that right back into programs, services, and other investments in the organization to advance the mission.
With the increase in the Medicaid program, does that have a consequence for you guys?
Medicaid expansion? No, Medicaid expansion doesn't really impact us too much because the target for Medicaid expansion typically is going to be a young family or children. Yeah, and so since we tend to not serve them as much, it doesn't impact us too much. We have evidence-based programs. Actually under Assistant Secretary Kathy Greenlee during the Obama administration, she conceived of this idea to have evidence-based practice as a part of the area agencies on aging to make sure that they were actually doing something that had science behind it. And so they started courses that were disease prevention and health promotion. And there's a small funding line under the Older Americans Act to help us do that. These are typically in the community at a library, senior center, hospital even sometimes. A lay leader will come in and it's a peer-to-peer learning opportunity. They follow a curriculum that is known. If you follow it this way, it will have these evidence-based outcomes, of course. And they work on falls prevention. They work on looking at how to manage chronic disease, socialization, finances, the things that you might expect would really lead to very nice outcomes. And those are virtual as well. We made that transition during COVID. And we actually collaborate with area agencies on aging across the state of Missouri so that if there's a shortage in a leader, we can bring one on and offer a virtual class. It's worked quite well. Additional suite of those evidence-based programs on this slide. And this is something we're very excited about. This happened in the past couple of years. I'm going to walk through this model. We are trying to make this easy to understand, but it's kind of steep in the jargon. I'm glad to have faculty. You probably pick it up quicker than most audiences. But we have operated this new model of programming for the past few years, and it has been quite successful, but we're still dealing with structural lag at the federal level as they try to realign healthcare reimbursement mechanisms. So as you know, we have insurance companies and hospitals throughout the region. Increasingly, under their reimbursement models, they're being called to really take the risk on financially for their members or patients in their long-term outcomes. So that's, you know, it went from a fee-for-service or volume-based reimbursement now to value-based. We're going to look at outcomes and only reimburse you for good outcomes. A very logical thing to do, but what has been very difficult for our healthcare entities in the region is to do so, you need to influence how lives are lived in the community. And if you operate a clinic with 4 walls, it's very difficult to fund and understand how those programs and supports actually are going to work. So we formed a network of our community-based organizations, our nonprofit service providers, to contract with healthcare and insurance to provide that array of services for reimbursement because we are reducing their risk and they are being reimbursed for what we are doing. So this extends beyond those patients who are eligible through Medicaid or eligible through normal Older Americans Act funding. These clients and patients come to us with a funding source in hand. So we receive referrals, and we have created the Mid-America Community Support Network. That's housed at MARC. All it is an administrative entity that helps take in one single contract from healthcare and then work with the community-based organizations to make referrals, make sure we're HIPAA compliant, which is very important, and make sure that billing can be accomplished. This means that the individual nonprofits, they might be 2 or 3 people deep, and that's all the staffing that they have. They don't have to mess around with the federal reimbursement, have all the computer systems and infrastructure. They can just work directly with us and access these dollars without all the expense and infrastructure. So that is really who wraps around this and makes it work, are those frontline nonprofit service providers. And then they bring to bear the services that they've done so well in the community for so long. And then we're able to centrally provide data and reporting back to the health insurance company or hospital and they continue to fund the system because of good outcomes and et cetera, et cetera. So that started during COVID when Blue Cross Blue Shield of Kansas City said, we have a huge membership across all of our plans, products, and services that have tested positive for COVID, and they are now self-isolating. What do we do to support them? Can we get them food? Can we get them a care manager to talk through, their needs and get them connected to healthcare? And we said, actually, the community is prepared and ready to do that. We could really serve those members. And so that is when that started, and it has expanded from there and been a very positive revenue source for our community-based organization partners. So I wanted to make sure we hit that. That's new. It's a different concept. The federal government is pushing it at area agencies on aging to do this type of work. And we think in the future it will be important to this new value-based environment. So other than that, I wanted to ask you guys a couple of questions and see if I could get some of your wisdom and feedback. So my first question is about the narrative of aging and growing older. And we recognize, at least from my view and my role, we recognize that sort of the normal narrative is you kind of go along your life, you're doing fine, and eventually you're going to get to a point. No one knows exactly when, but it's going to come when you make the step into a nursing home. And especially in states like Missouri that haven't had a lot of really progressive ideas about how the life course might advance into older age and towards death, that's a natural step to go into a facility. And so we would like that narrative to change, just what is talked about among people and how you view stepping into older age and lower function as is the natural course, and to really think about community and place as paramount and important, and being able to have a choice of remaining where you want to, which is typically where you've been living, but it also might be another home in the community, but still outside of an institution. So I just wanted to open that idea up to you all and see, is that the common narrative? Is that really the dominant narrative in Kansas City, that we're going to eventually step into a nursing home? And if not, how do we change that? And if not, what is the dominant narrative? I'd really love to hear your reactions and thoughts to that question. Go ahead.
Well, I'll say something first. I'm Linda Brightsprock, and I used to work with some of your former people who preceded you, like Jackie Moore, and before her even Jean Bacon, and but now as a retiree and with lots of friends some of whom are facing real health changes. I think, most of them are saying they would avoid a nursing home like the plague. They're looking more many of them are looking to downsize, but they're looking either for, condos or apartments, or for a CCRC type of living environment where they can get continuous care, moving, the opportunity where as their as their health changes, they can move from an independent living situation into assisted living and eventually into full health care if that is needed. So I think that's that's one way people are talking about going. But the other is that many people are really trying to modify their homes so that they can stay in their homes. I know that's kind of the way we've been approaching things.
Yeah, thank you. That's kind of my impression as well. And I think, of course, the approach really varies depending on what resources you have available to you, what you've been exposed to. But I'm very interested in the question of expectation about, what is the course going to be for the normal, and then the normal course of things, and then how do I kind of ingest that as my future? But I think you're exactly right. That's a lot of people are trying to shrug off the traditional, especially since COVID, as they kind of see that institutional living isn't maybe all that it was chalked up to be. Go ahead.
I live in the Johnson County area at the Kansas site, and obviously it's a very affluent, generally affluent situation. And I see exactly that type of shifting from living at home, and if you can't do that, or you make the choice to go to an assisted living situation in which necessary care may be closer by, easier access, and if a catastrophic medical situation occurs, to have the opportunity to take care of that either in that assisted living or in a full care facility.
Yeah.
But I think that that's a fairly ideal situation because of the affluence, the capabilities that people have.
Yeah, yeah. You know, a really wise person in aging told me, you know, his forecast, and this was in the early 2000s, maybe a little bit earlier than that, was that advocacy currently was how to get people out of nursing homes. And eventually, you know, the demand would shift in a way that we, in the future, will be advocating for those with fewer resources to have access when they finally need the nursing home, because it will be such an acute level of care that we're going to have to advocate for those with few resources. Otherwise, they'll be bought out by those with a lot. I think that's very true. Go ahead.
One year, I had a good fortune of being a nurse practitioner, and when my parents were in their 80s and developing memory issues and Alzheimer's, I had the knowledge, you know, to come into the home. The area that I think is missing in most homes is advocating for the person going to the hospital, the emergency room, coordinating all the information if you're not medical, and then getting back home and doing it.
Yep.
It's almost like people need an advocate, a hospital advocate, or a respite person in the home.
Yeah.
And I think family members take over and do it and end up maybe giving up their own professions in order to
yeah.
It's not reimbursed, and so it's kind of tricky. I mean, a lot of my friends who have family members with ALS are doing around the clock care, but they're not being reimbursed. If you hired someone to do the section, they would do.
Yeah.
I don't know if there is reimbursement for non-professionals.
Other than the veteran-directed care program that I spoke about, it's few and far between. There is some consumer-directed when you slip into Medicaid, but you know that's not generally the first thing that the majority of people turn to. By the way, if you ask Kathy Greenlee, if you get the opportunity, and she is in the region, she has this amazingly powerful statement that we all are on our way to being Medicaid dependent. I mean, even if you're upper middle class, it's still likely that you will exhaust your resources in your lifetime and be Medicaid dependent. But it's not the first thing, you know, that you would turn to at the point of a crisis, that turning point and function after the hospital discharge. You know, you'd really need some assistance. I think that's right. There are very few structures right now that support payments into those systems that can maintain that relationship other than the veteran-directed care program that I mentioned. I think they might be coming. I think consumer demand is actually pushing that, and voting is pushing that to some degree, but it's not very formal yet. It's not very mature. We're actually exercising a pilot program right now at University Hospital and St. Luke's, and maybe Olathe Regional soon, where we're working on the cardiac floors for recent inpatient stays and helping to place one of our community liaisons directly on that clinic floor. And they'll talk with the patient about social needs before the transition and help get that stuff established and ready to go when they're back in the home, typically for people who are of higher or lower income, you know, or higher need. And that's been a really just breath of fresh air for those patients who face remarkable changes and very little help instrumentally on the community side. They might get some medical care, they might get some pharmacy care, but what do I need? Transportation, how do I get that ramp built on my front porch? That type of thing is hardly ever addressed.
else them when they're in the crisis.
Yeah.
They get, you know, even if it's written down, it's nice to have another set of.
Yeah. I've matured in my reaction because I used to get really angry at hospitals. I'm like, why would you treat people in this way? But it's not their fault. You know, it really isn't. They have low staffing, low time, and they are dedicated at that moment to getting your body functioning, which is a huge specialized task. And to think holistically beyond that about the next step is just a challenge that I don't think we can lay at the feet of hospitals and be very effective.
One people suffers profound dementia, the other one is failing harder, but not perhaps sitting very well.
Could you repeat?
Yeah, I will repeat that question. It's a little quiet. So the situation, our scenario is in a neighborhood and the individual receiving care has dementia, suffering from dementia. It seems like progressing quite a bit, and the caregiver, him or herself, is not the best suited to provide care, maybe not the best situation for caregiving. So this is a major question of our time, right? It's one of the top questions. What do we do with people who enter into dementia because the functional levels decline so rapidly and the needed supports are so high? So there are some resources for training up the caregiver and helping them deal with the stress and the routines that they're faced with. How do you intervene in a way that can alter behavior effectively? And what are some of the access points for pharmaceutical support in some of those situations? But that's not it's not a rigid structure in our society. So it's really hard for people to find that and access it. So it's immature, but some of that does exist. But otherwise, individuals with dementia are probably the most suited to making that transition to an institution because of the just extreme complexity of dealing with holistic behaviors and everything else that comes with dementia. But you can achieve some level of delaying that or making it a little bit better for the caregiver and the community with some resources that exist. They just aren't very robust, fortunately. That's a great question. I think that that was kind of where I wanted to have some input or feedback. Go ahead.
Go.
Did we have a question? Okay. But I just really appreciate the opportunity to tell you about our services. This is a monumental task. You can feel the change in people who need services over just a short period of time. So even the 5 years I've been at MARC, it's increasing every day. And right now we have exceptional challenges with staffing across all areas of our work. And so we haven't answered the question of what do you do? Who are the people who provide care to these older adults that we've just never seen this proportion of our society in need? And it's really interesting because some of the things that would have probably addressed that need have already happened 20 years ago, like fertility rates or immigration policy that would have just changed that dynamic. It's too late now, so we have to find a different way forward. So with that, I will conclude and happy to take any additional questions or have further discussions.
Thank you.
Thank you.
I have a quick question if if you have a minute.
Please go ahead.
How is the funding level from the Older Americans Act going? Has it continued to go up, or I mean, I used to follow this, but I haven't really watched it in the last couple of years. I know the act has to be reauthorized every few years.
Yeah, there has not been an increase in the Older Americans Act concomitant with the increase in population share of older people ever. Even in these times of extreme relief coming through, some of that has occurred. As you all are aware, there's an excess, not an excess, there's a bulge of funding in the systems now across every federal program. It's interesting in acts like the Older Americans Act, the restrictions and regulations on how those dollars are spent necessarily constrict us to very defined pipelines into the community. So I like to tell our state regulators, because they have literally told me you have too much money, and so therefore we're not going to advocate for more money in the future. I say we have rickety plumbing from this tub of a funding source into the community, and it's leaking here and there, and we have low staffing. We can't buy equipment because the equipment has supply chain restrictions, and that dribbles out into the community. We need to build that infrastructure, upgrade the plumbing itself, have better facilities, better professionals that are more deeply trained, and a broader workforce. I can't spend a dime of Older Americans Act on any of those things. Technology, it's really hard to spend on technology investments under these federal funding. We need other dollars to help make that actually flow into the community effectively. So the answer is no. The Older Americans Act in general, except for COVID, the COVID period of time, have not increased concomitant with the increasing population.
Okay. Once more, thank you very much.
Thank you.
Thank you very much.
Of course.